very warm welcome to you all. I am Dr. Nandini Sethuraman and I head the Department of Clinical Microbiology at Apollo Hospitals in Greaves Road. Today we'll be looking at some common microbiological investigations and how to interpret common culture reports and susceptibility test reports. Clinical microbiology is a science that deals with the diagnosis of infections. So this is also very much dependent on a good rapport between the lab and the clinician. And this diagnosis is made best with the availability of the most important parameter, that is an appropriate specimen. So the common dictum of garbage in, garbage out really applies to microbiology because this is a science of interpretive judgment and only the quality of the specimen will determine the quality of the reports as well. Microbiological investigations can be broadly classified into direct tests and indirect tests. Direct tests basically look directly for the pathogen of interest. So broadly you can classify them into tests which are based on microscopy and conventional culture. Also, there are subunit detections which look at parts of the pathogen. It could be a virus or bacteria. So detection of antigen, detection of nucleic acids like DNA and RNA are also direct detection tests. And then we have indirect detection tests where you look at the host's response to an infection. So basically you're looking at antibody presence for particular organisms. There can also be presence of other markers of infection which are not directly related to the organism, which we call as biomarkers. Biomarkers help us to predict whether a particular process of fever or sepsis is due to a bacteria or virus or it is due to something else entirely. Like you have examples like C-reactive protein and procalcitonin. Specimen collection is the most crucial step for determining good quality microbiology reports. So when adequate samples are not collected, two things can happen. One is the organism of interest can die off during transport delays, or there can be an overgrowth by contaminants. Clinical specimens for microbiology can be broadly categorized into two. One category is those samples which are obtained from normally sterile sites. So in these sites, you don't expect any bacteria to be normally present, like blood, pericardial fluid, pleural fluid, etc. So even a single colony will be significant. On the other hand, you have heavily colonized specimens like skin, stool, sputum, throat, etc., where there will be a lot of normal commensal flora already present. So you have to really search for the pathogen of interest. In between these two is another category where there are specimens which have a significance threshold. The common examples are urine and endotracheal aspirates, where there is a threshold beyond which only we attribute significance. We'll now look at some of the common microbiological investigations. The most rapid test in microbiology is actually the microscopy. So you have several stains which are commonly sent to the microbiology lab. Common ones being Gram stain, AFB stain or the Zeal-Nielsen stain, and a KOH or a potassium hydroxide mount done for fungi. The Gram stain has very high specificity, especially in certain syndromes where you expect only one or two kinds of bacteria to be the causative agent. For example, if you have a patient with a urethral discharge and you perform a Gram stain and you find that there are Gram-negative diplococci, it is most likely Neisseria gonorrhoeae. Similarly, if you have a well-collected sputum specimen from a patient who has a community-acquired bacterial pneumonia and you find that there are Gram-positive diplococci surrounded by a capsule, it is most likely a Streptococcus pneumoniae. Similarly, when we have bacteremias, the blood culture flags positive, we first perform a Gram stain on that to see what kind of organism is causing the sepsis. It's usually either a Gram-positive cocci or a Gram-negative bacilli. So this is immediately informed to the clinician who starts a broad spectrum Gram-negative or Gram-positive cover accordingly. Another microscopic technique is the acid-fast stain or the Zeal-Nielsen stain, which is primarily done to look for tuberculosis bacilli, that is Mycobacterium tuberculosis. So this technique can also be used to look for other non-tuberculous mycobacteria like NTMs, which frequently cause surgical site infections and also atypical mycobacterial disease. There are some modifications of the AFB stain that are done to look for organisms like Nocardia and also the Cryptosporidium oocysts in the stool in the appropriate host. Another microscopic technique that we do to detect fungal infections is the potassium hydroxide mount. Now this is not really a stain, it is just a reagent that we use to digest tissues so that fungi become more prominent. So especially from invasive specimens like tissues, when we do a potassium hydroxide mount, we immediately know whether there is a presence of a fungal infection. This can be really critical to initiate appropriate antifungals. In the cerebrospinal fluid, we do a negative stain known as the India ink or the nigrosin stain to look for capsulated yeast-like organisms, that is usually Cryptococcus. So this is a common cause of meningitis in HIV hosts with advanced AIDS syndromes. Let's now try to understand bacterial cultures. This is a very frequently asked investigation. There are certain processes which are involved in finally giving out a report of a bacterial culture. First, we need to isolate the organism. So I told you that there are both sterile specimens and unsterile specimens. Sterile specimens, usually we give a combination of enriched media to increase the yield of these organisms. In case of unsterile specimens, we give a combination of selective media to specifically isolate the organism of interest and suppress organisms that we are not interested in. Once we have isolated the organism of interest, we need to identify what it is. So there are two ways to do it. One is a conventional set of biochemical reactions that we set up. Apart from that, we have more sophisticated automated methods now to identify these organisms. Based on the identity of the organism, we then go ahead and set up a panel of antibiotics for susceptibility testing. So what are the situations where you would order a bacterial culture? First, you need to identify that this patient probably has an infectious disease syndrome going on. And you need to identify which is the system of affection of this infectious disease syndrome. So just having a fever and sending all specimens from all over the body is not the right way to do it. You identify the syndrome of interest and then the specimen of interest based on that syndrome. So for example, if you think that your patient has a pneumonia, you have to draw respiratory specimens. If you think that he has a UTI, you draw urine specimen or more invasive specimens. A common investigation that is very important and gives you a lot of information is the blood culture. This is a paramount important investigation, not only for primary bacteremias like line-related infections, even for infections in other systems, there can be secondary seeding of the blood leading to secondary bacteremias, where blood cultures can tell you what is the organism causing the infection. Another important thing to remember is that cultures should always be drawn before antibiotics are administered. I told you earlier that administration of antibiotic delay results in an increase in the mortality, but still it is important to draw cultures before you start antibiotic therapy. Once you've sent the appropriate bacterial cultures, the next step is to start empiric antibiotics. To know what antibiotics to start, obviously you need to know this is the syndrome of interest and the organisms causing that syndrome. So it is important not to develop a favoritism to antibiotics. For example, I will start ceftriaxone for every infection. It's not like that. You need to know what are the common organisms that cause that syndrome and what antibiotics they will be susceptible to. For example, this is a figure that shows susceptibility of various organisms to antibiotics. So what is the spectrum of these antibiotics to these organisms? If you look at a drug like vancomycin, for example, it is a drug which is only used for treatment of gram-positive infections. It will have no spectrum against gram-negative bacilli. Similarly, drugs like colistin, polymyxins will not have any spectrum against gram-positive organisms. And also among the cephalosporins, there are various generations of cephalosporins. The first two generations are mainly for gram-positive organisms. Third generations are for gram-negative organisms. Carbapenems are very high-end drugs which usually cover many of the gram-positives as well as gram-negatives. But importantly, they will not cover MRSA. So it is important to know what drug covers which organism before you blindly give antibiotics for every possible organism. Based on the antimicrobial spectrum of these antibiotics, many organisms are intrinsically resistant to a bunch of antibiotics. For example, if you want to treat an infection due to Proteus, you can never use colistin because Proteus is intrinsically resistant to colistin. Apart from this, there are mechanisms in which organisms will acquire resistance. For example, one of the paths of acquisition of resistance is by selection of antibiotic resistant mutants after antibiotic exposure. So there will always be a resistant subpopulation which in the presence of the antibiotic will be selected out, and that population alone will flourish. Another mechanism of acquiring resistance is by superinfection with a new organism to which that antibiotic is not effective. So the initial antibiotic pressure takes care of the original organism, but another organism which is resistant to that drug can flourish as a superinfection. The third important mechanism of resistance acquisition is by horizontal gene transfer. So both the bacterial chromosome as well as extra chromosomal elements like plasmids can carry antibiotic resistance genes. These genes can travel from one bacteria to another within the same species, but also they can cross over species. For example, antibiotic resistance like extended spectrum beta-lactamases and carbapenemases have crossed species barriers from E. coli to Klebsiella and so on. So this is a dangerous form of resistance that can spread across borders also. Now with this knowledge of intrinsic resistance and acquired resistance, let us look at a few microbiological reports and see how to interpret them and use the best antibiotic for those particular cases. Let's first look at this case. This is a patient who has a infection of the flank and a pus was drawn from the flank, and the gram stain showed that there were white blood cells or pus cells and occasionally gram-positive cocaine clusters. This was identified later as Staphylococcus aureus. Now we look at the susceptibility report here. I would look most importantly for one particular drug here. So this is oxacillin. So this organism is oxacillin sensitive, which means that it is a MSSA or methicillin sensitive Staph aureus. What this means is that this organism will be sensitive to cloxacillin, cefazolin and all other beta-lactams. So I don't need to look specifically at drugs like ceftriaxone or meropenem or anything. It will be susceptible to all, and the choice of antibiotic for an MSSA is either a cloxacillin or a cefazolin. Another thing to note here is the D-test positivity. So D-test is a test that we do for inducible clindamycin resistance. So this report shows that it is a clindamycin resistant isolate even though the MIC is quite low. But in this case, we should refrain from using clindamycin for this because the D-test is positive. Let's look at another case of an abscess of the thigh. So this pus was drawn and the gram stain showed that there were pus cells and occasional gram-positive cocaine clusters. The culture grew Staphylococcus aureus again. In this case, however, if you look at the oxacillin, it has been reported as resistant. Similarly, if you look at ceftriaxone, it has been reported as resistant even though the MIC is low, that is less than 8. So what we need to observe here is that every oxacillin resistant Staphylococcus aureus is a MRSA, that is methicillin resistant Staph aureus. MRSAs will be resistant to oxacillin, cloxacillin, cefazolin and all other beta-lactams including carbapenems. So if it is an MRSA, even though MICs may show low for ceftriaxone or carbapenems, you cannot use any of these drugs. You'll have to go for alternates like MRSA active agents like vancomycin. Now let's move on to some gram negatives. This is a report of a patient's blood culture who has a pyelonephritis. So the culture from the blood grew Escherichia coli and the susceptibility report looks like this. So on the initial glance, all the drugs look susceptible except trimethoprim sulfamethoxazole. So usually the choice of antibiotic here would be a narrowest spectrum possible. That is a third generation cephalosporin monotherapy is definitely indicated. Something like cefotaxime or ceftriaxone can be used. Another similar report of another patient with pyelonephritis. Susceptibilities are slightly different. If you look here, this is an isolate which is resistant to ampicillin, aztreonam, cefazolin, ceftazidime, ceftriaxone, cefuroxime. Basically all third generation cephalosporins as well as aztreonam, but it is sensitive to meropenem. So this is likely an extended spectrum beta-lactamase producing E. coli which is resistant to all the third generation cephalosporins, but here you can go ahead and use carbapenems. Now we look at case 3. This is another patient with pyelonephritis whose blood culture grew another organism called Enterobacter cloacae. Now this is also an organism closely related to E. coli, but it has a certain important characteristic. So if you look here, the ceftazidime, ceftriaxone, cefuroxime, the third generation cephalosporins basically, all their MICs are on the lower range, but still they have not been reported as susceptible because Enterobacter cloacae is an organism that produces a mechanism of resistance called AMP-C intrinsically. So for any of the Enterobacters, even if it has been reported sensitive, you cannot use third generation cephalosporin as monotherapy. Usually it should be used as combination, because on treatment these patients may go on to develop third generation cephalosporin resistance. So either use a carbapenem to treat these infections or use third generation cephalosporins in combination. In conclusion, here are some take home points. Specimen collection is the most important step to obtaining a good quality microbiological report. Interpretation of microbiological reports is dependent on many factors, including the site of the specimen and the sterility of the specimen, and also the intrinsic resistance profiles of those organisms. Every organism is unique, not only in its ability to cause infections, but also in the way it reacts to different antibiotics. Your antibiotic choice affects not only your patient and not only his local environment, but also the entire state and country, the whole community at large. So it is rightfully important to choose the right drug, to choose the right dosage, duration, and to de-escalate whenever possible from a broad spectrum to a narrow spectrum. So there are many other investigations in microbiology that are very useful. Most recently, you would have all heard of the COVID RT-PCR as well. Today, what we have focused on are the investigations that will help you to choose right antibiotics and to choose antibiotics that will prevent emergence of resistance in the future. So my advice to you would be to use antibiotics wisely and be responsible with your antibiotic usage. Thank you.